Thank you. Great. So we're very fortunate to have Carol Hartigan, who is a physiatrist working in Boston and has expertise in the role of functional restoration for both the walking wounded and the even worse than that.
Good afternoon, everyone. Thank you very much. I'd like to thank the North American Spine Society and Jerome for putting us all together and for his collegiality and friendship over many years. I'm going to speak about functional restoration for chronic low back pain. Jerome reminded me that this would be an audience that was sophisticated in the care of spine, but perhaps didn't feel completely sophisticated about the rehabilitation of people with spine problems. I know that the audience is a lot of surgeons, anesthesiologists, maybe neuroradiologists, neurologists, other pain clinicians, and probably some physiatrists. What I plan to do is review the basic principles of functional restoration, review the relevant literature, describe some simple applications that surgeons can use in their offices to facilitate improvement in function, and then describe one variation on possible functional restoration programs. So, in spite of exhaustive and usually repetitive diagnostics, most patients with chronic low back pain do not have a clear, indisputable diagnosis upon which we can all agree. And though they have had every test in the book and they may have age-appropriate degenerative changes, if we assume that they have had ruled out any serious problems such as cancer, infection, fracture, tumor, then we can argue about the etiology of the pain and the pain generators. We may argue which of the diagnostic test findings are clinically relevant and which are clinically silent. But one thing about which we cannot argue is that there is no serious process. This is not a dangerous, life-threatening problem. And for me, and I hope for many of us by the time this afternoon is out, we may agree that this may be the important fact, the most important fact about chronic low back pain, that the pain really is safe and that hurt really does not equal harm. And if we believe that, it can make a big difference in our treatment. Most patients with chronic low back pain have failed to respond to every treatment in the book. They've been around the block on the menu of treatments and they still have pain and they're still dysfunctional. Many, many studies have been done documenting the fact that patients with chronic low back pain are deconditioned. They're very deconditioned. They have great reductions in flexibility, in strength. They have demonstrated muscular atrophy. Their trunk extensor flexor ratios are reduced with a reduction in extensor strength disproportionate to that in reduction of flexor strength. Lifting capacity is impaired and aerobic capacity is impaired. These people are disabled and dysfunctional, and they are fear avoidant. So what can we do with them? What are our options? Well, we can repeat the treatments. We can do more hot pack, ultrasound, E-stim, massage. We can do more Williams-style pelvic tilts. We can do bridging. We can find new treatments. We spoke of some of these. We can do VAX-D. We can do prolotherapy. We can do complementary alternative medicine treatments. The menu is hard to exhaust. By chance, in Logan Airport, on my way here, I ended up having a woman do a reflexology treatment to my foot, and she came up with a very complex and focused diagnosis of my back pain, which I thought was very interesting as I was on my way here. Usually it's the taxi driver, but what else can we do with this population? Well, fairly simply, we can employ exercise and deliver the message that it is safe to function in the setting of pain. Kind of simple. This kind of treatment goes by many names. It's known as functional restoration, functionally oriented rehabilitation, quota-based non-pain contingent conditioning, intensive rehab with cognitive behavioral approach or an operant conditioning approach. Sometimes it goes by the name of spinal stabilization or core strengthening. And our patients in Boston affectionately call this treatment boot camp. There are two common themes to this treatment: sequentially and methodically increased intensity exercise and a sequentially and methodically increased supportive message to increase exercise and activity and life function. So what do we know about this sort of treatment? How does it compare to fusion? There are two good studies that look at this kind of cognitive-based intensive exercise and compare it to fusion. One of these studies by Brox was published in 2003, and it compared 62 patients who were randomized to either cognitive rehabilitation and exercise or fusion surgery. And the study found that at 1-year follow-up, both groups demonstrated significant improvements in the outcomes of back pain, visual analog scale, disability, analgesic use, satisfaction with care, and return to work, as well as distress. There were no differences between the groups at 1-year follow-up. The second study of over 200 patients randomized patients to either education and intensive exercise or fusion. And this study also found that there was no significant difference in the improvements in the groups at the 2-year follow-up for their disability outcomes or the shuttle walking test. So these studies show that fusion, which is based on the premise of stabilizing pain-producing structures, led to no better improvements than advising patients that it is safe, in fact beneficial, to move and engage in ordinary activities and link that advice along with progressive exercises. The studies employed simple, accessible exercises and advice, nothing rocket science, endurance and coordination, stretching and strengthening, trunk and abdominal contraction, and activity advice. And a question that comes up is what would be the best dose for functional restoration? And it used to be when functional restoration surfaced that these were programs where people attended 8 hours a day, 5 days a week for up to 8 or 10 weeks at a time, which was very time consuming and very expensive and employed numerous different experts in the treatment. And now we know that there are a number of studies, where are we? Let me go ahead a sec, that look at the dose of treatment. One study compared 132 patients who were randomized to either 15 hours of directed non-pain contingent exercise versus 150 hours of multidimensional rehabilitation. And the active individual exercise group, which received a safe functional message, attended therapy for an hour 3 times a week for 5 weeks, while the functional restoration group attended for 6 hours a day, 5 days per week for 5 weeks. And this study showed that both groups improved equally in pain, disability, and return to work, and the dose of treatment did not matter. The group that received longer treatment actually did better in their physical performance for flexibility, strength, and cardio endurance. I'm just going to come back now and look at one other question which comes up, which is it the message or is it the exercise that makes a difference? And another study actually looked at randomizing 223 patients into an active physical treatment that attended therapy 3 times a week for 1 hour at a time for 10 weeks versus a group that had cognitive behavioral treatment, which involved guided imagery and actual planning to increase activity and to respond to pain differently in 17 1/2-hour sessions versus a group that received both treatments, and that was compared to a waiting list group. And it was found that there was no difference in the significant improvements in the 3 treatment groups compared to the waiting list group in pain, disability, and pain catastrophizing. In fact, the physical treatment that did not deliberately target cognitive factors led to improvements, and the cognitive treatment that did not deliberately target physical factors led to improvement. So in addition to dose, another study on dose was done by our clinic where we compared 80 consecutive patients who received either 2 times per week versus 3 times per week treatment for 90-minute sessions for 6 weeks of our functional restoration, non-pain contingent, cognitively focused program. And we found that both of those groups at 1-year follow-up demonstrated significant improvements in pain, disability, and physical performance without any difference between the groups. A more recent study that we did looked at our groups undergoing either 1 set versus 2 sets of our resisted exercises and found that there was no difference in outcome to those who underwent the one set versus the two sets of treatment. The common thread to success in all of the studies I've mentioned is not specific exercise, it's a variety of exercise, and it's the methodical, sequential, increased exercise dose. It's quota-based, progressive resisted, not contingent on pain, delivered with a message of safety, and along with concrete instruction to increase functional activities, specifically tailored to the patient's world and needs. Now, how specific does the exercise treatment need to be in functional restoration? In the world of rehabilitation, the convictions of some clinicians about the specificity of exercise required to treat chronic low back pain are exceedingly strong at times. One study looked at 55 patients who were randomized to plain old general endurance trunk strengthening exercises versus a group that was randomized to special spinal stabilization exercises, which I don't know if we'll hear about, basically consist of co-contracting the abdominal muscles with the multifidi muscles, pulling up the pelvic floor, gussying up the thoracolumbar fascia, and proceeding, often with avoidance of flexion. And this study showed that there was no clinical difference. Both groups improved significantly in strength and function, and there was no superiority of one of the treatments over the others. Another specialized treatment that is often offered for chronic low back pain is the McKenzie Method. This is a method that is proprietary. It is a treatment that is based on a complex classification. Advocates of this treatment recommend that this treatment be applied by certified practitioners. Applicants for certification are required to undergo 4 courses of 3 to 4 days each, followed by a certification exam to receive their certification. This is about a $2,500 process, and it requires at least 14 or 15 days. Recertification is required, and individuals who are certified have an opportunity to go on to receive a status of becoming a diplomat. This is a little bit less accessible than basic exercise. It is a little more complex. A recent review demonstrated that 2 of 3 high-quality studies found very good inter-rater reliability in the classification upon which the treatment is based, but 1 of the 3 studies that was high quality was found to have poor inter-rater reliability. So how does this work out in the clinical setting? We can do theorized, specialized treatment methods, but we need to look at them clinically. In fact, 2 recent studies from the same group showed that when 270 patients were randomized to undergo the McKenzie Method treatment versus less specialized intensive dynamic strengthening twice weekly for 8 weeks, both groups improved equally well in pain and disability at 8-month and 1-year follow-up. Fairly good follow-up points. The treatments were equally effective. Neither one was superior to the other. We spoke a little bit about McGill. There are a lot of other theoretical classification systems out there that make a lot of academic sense but have not necessarily been tested clinically. One of these methods looks at the diagnostic test, the MRI scan findings, and the complex physical examination maneuvers, and categorizes patients into compression intolerant versus shear intolerant versus flexion intolerant. Corrective exercises are imposed based on these diagnoses. Patients are told to avoid load-sparing postures, to avoid joint loading. In this particular treatment method, if a patient has a disc bulge, they're told to avoid spine flexion. And we all know that disc bulges are very common and often seen in people who do not have any pain. The message conveyed with this sort of classification method is somewhat complex. All of this in the face of epidemiologic literature demonstrate that even people who participate in high-level leisure time sports activities, which involve flexion and impact, any other exercises including running, skating, etc., prolonged sitting, standing, and walking are not associated as having a higher risk for developing low back pain. So I would propose that it is not necessary, and it may be adverse, to advise our patients to move thoughtfully and specially. Our review of intensive versus low intensity or conventional treatment favors intensive treatment for chronic low back pain. Chow's recent review in spine recommends that intensive rehabilitation with cognitively behavioral orientation is strongly recommended for patients with chronic low back pain. It's the strongest recommendation for treatment based on high quality evidence. So how is this done? Well, in our clinic, obviously, the final rehabilitation effort focuses on function, and pain is an entirely secondary goal. This is all about getting a life. It starts with the physician evaluation, where the onus of responsibility is on the physician to actually look at the MRIs and all the tests themselves, to evaluate the patient, do a physical examination, and rule out that serious process. Then to begin the process of education regarding the safety of pain and the lack of expectation for sudden functional recovery or reduction in pain if they continue on the same course. The patient's fears and inhibitions of movements are confronted. The documentation of the reduced flexibility is confronted. The sense of deconditioning, dysfunction, guarding, fragility, and fear avoidance are discussed. And optimism is conveyed for potential for functional improvement with a challenging conditioning program. I usually confront patients about their probable skepticism regarding the counterintuitive nature of my recommendations, which include, oh, even though your back hurts, we're going to have you pushing weight on a back machine, doing the rotary torso, bending and lifting, working your hips, doing some cardio, and each time you come in, we're going to challenge it more, even if it aggravates your pain initially. The worst that can happen is that you can get stronger and more fit. I also take a moment to disabuse the patient of possible previously imposed far-fetched and hyper-analytical diagnosis that they may have received. Anything from that their SI joint is misaligned and coming out of joint and needs to be placed back to joint, or this more extreme example that I received recently. This is a letter I received from a physical therapist regarding a patient, and I'll just move quickly through this. This person was felt to have a right upslipped ilia, a rotated and abducted ilia right, a posterior ilia left, bilateral superiorly stuck sacrum, coccygeal rotation, L5S1 torsion, right stuck SI joint, positional faults, difficulty holding corrections, lumbosacral restrictions, dural restrictions, and peripheral nerve restrictions, especially right femoral. Such confrontations, when I tell the patient that it's hard for me to go along with these diagnoses, are extremely well met and very much appreciated. So what else do we do? We get people working out in their 90-minute sessions twice a week, doing 30 minutes of stretching in a group. We're pushing for improvement in their flexibility every time they come in. This is followed by 30 minutes of cardio, and they don't just do the same old cardio every time. We measure it and we look for improvements, followed by resisted strengthening. During the treatment, we're encouraging individualized return to function depending on their own individual needs. We use a quota-based non-pain contingent approach where we methodically and sequentially increase the challenge of the exercise. We measure flexibility, we measure 4 repetition maximums for strength, and we measure cardio endurance using the YMCA endurance test, and we look for improvement. From day one, we have patients working the machines on their own. They're planning to transition to a health club when they complete treatment. They've had back pain for years. They can't just have 6 weeks of treatment and go home. They have to have a plan, and we're going to confront them about their barriers to exercise if they mention those. We also review the previous physical therapy flaws. Many people say, oh, I already had aggressive conditioning. I got on the back machine, but when we ask them how high they got, they either say, I don't know because the physical therapist set the equipment for me, or they say that someone my size might say, oh, we got up to about 40 pounds when someone my size should have gotten up to about 130 pounds on the back extension machine. We also talk about the mixed message that even if some people have had some effort at intensive exercise treatment, often it's been provided with a mixed message of, oh, you're feeling a little worse today, let's get you over on the exam table, give you a little hot pack, a little ultrasound, a little e-stim, a little massage, and remobilize that joint for you. We do the Roman chair. This is controversial. We never get people on the Roman chair, which is erroneously known as the hyperextension machine unless they've achieved 50% of their ideal body weight on the back extension machine. And we do this not even so much for back strength as we do for overcoming the kinesiophobia. If you can get on the Roman chair and hold for 2 minutes isometrically or do 20 repetitions, you're not afraid of your back. We also do freestyle lifting, and we do freestyle lifting not because it's important to freestyle lift, because people have been told that they can't bend. And this is also about overcoming kinesiophobia. And we may have some arguments among our group here today, but the biomechanical literature does not support advocating squat versus stoop lifting. And I wish that Alf Nackhamson were here to weigh in on his own studies that he believes were highly misinterpreted when he looked at disc pressure many years ago. The point of this station is about overcoming kinesiophobia, and it is okay to tell our patients to lift everyday weights normally. When we do the lifting station, a person my size will get up to about 30 pounds of lifting. That's lifting the baby, lifting the briefcase, doing the laundry, emptying the dishwasher, working in the garden, and getting a life. Finally, we do some multi-hip, and we always do some upper body conditioning, and we give people a concrete program to take to the gym. I have just 2 or 3 more slides. We looked at the long-term exercise adherence in 122 consecutive patients who completed our program, and we found that at 1-year follow-up, the majority of these patients were reporting that they were still exercising more than 3 times a week at the gym, doing stretching exercises, aerobic activity, back strengthening, and general strength training. And we attributed this to the fact that we were challenging them and confronting them from the first day of treatment. So the conclusions today from my talk are that intensive non-pain contingent spine rehabilitation is safe, effective, can be simple, and is accessible. It does lessen physical impairments. It lessens spinal-related disability, reduces pain, puts the ball in the patient's court, and changes exercise habits. Surgeons and other providers can support the message of safety, seek collaborative healthcare providers, endorse restoration of function, and most of all, believe yourselves that chronic low back pain is safe. Thanks very much.
Great. Our next speaker is Heidi Prather. Heidi is a member of the NASS Board of Directors and will be speaking in the general session on the hip-spine interaction. And I can say that I've learned a lot about these mysterious ailments that don't seem to be coming from the back from Heidi, and I hope you can enjoy what she has to say.
And so my talk today is primarily going to be on posterior pelvic pain or pelvic girdle pain, and basically things outside the back that look like the back or go along with the back. I want you to think of them in that way, that they're not necessarily separate. So I got to ride a bike across Missouri with Joel Press, and I got to look at this guy's butt a long ways because he was a really good back rider. So my whole talk is really about butt pain. And really, it can look a lot like how people present to us with primary spine problems and primary hip problems, as well as primary SI joint problems. And maybe these are all continuums or coexisting things that occur together. So again, that's kind of the framework I want to put this in today. These are diagrams.